And again, we're going to have 3 excellent former fellows and residents that were involved in the program. Varshana Gurusamy is graduated from the class of 2021. She's currently at the Medical University of South Carolina. She's the Associate Program Director of Interventional Radiology there. Yoland Bryce is class of 2015, and she is at Memorial Sloan Kettering. She is the Residency Program Director for Interventional Radiology. And we have Timothy Yates, who graduated in the class of 2016. He currently works in an outpatient center, Palm Vascular Centers. So we have 3 very different perspectives as far as what they've done after their training, and we're going to listen to some of the thoughts that they have as far as the training program and how their careers have advanced since that time. So with that, I'd like to start with Varshana Gurusamy to kick it off and tell us about her experiences. Again, she is a fresh graduate. She just finished up her training and has moved on to other things. So Varshana, go ahead and take it away.
Thanks, Brian. First of all, I loved seeing that slideshow and those pictures of my class. I have to say, there's nobody on this panel that I haven't talked to in the last week, that I haven't texted or had a phone call with in the last week, which is amazing. And Tim, I just met on here, so you're probably next, but we're such a close family. My co-fellows and I talk all the time. I FaceTime with them, talk about cases. We talk about what it's like to be new attendings in our various practices. So it's, when you say it's a family, I mean, it's absolutely true. So I did just graduate in July, and I started at the Medical University of South Carolina at the end of September. So I'm about 7 weeks in as a new attending, and it's been amazing. So I always knew that I wanted to do academics. I always enjoyed teaching. I liked being in that environment, and that's sort of who I am. So that was the only type of job that I looked for. I wanted to be a part of a big university setting. And there was a lot during my fellowship that prepared me for that. So I had experience working with residents and medical students as they came through. We give presentations, we present to, vascular surgery. We do these vascular conferences every month. And at the time it seems painful, but you become really comfortable speaking about a subject. And the more and more you do it, the more comfortable you get. And I'm noticing as new faculty, I'm expected to give a lot of talks. And not only have I built up a library as a fellow, but I'm very comfortable speaking in front of people and on various subjects. So that was something that really helped me out, especially going into academics. So when I started at MUSC, the idea here was we had a very good practice. There's a lot of variety here. We're in the low country. People have diabetes, they smoke, there's good disease here, but no one had really championed peripheral arterial disease. So that was sort of what I was brought on to build here. And I think the reason that I was, selected for this job was, based on the reputation of the program. They knew how well I was trained, and they knew coming out of fellowship that this was something I would be able to do. And I had a lot of experience with practice building during fellowship. So I had experience talking to clinicians and referring providers, not as a resident speaking to an attending, but as a consultant to consultant. So I felt like I was speaking on their level. I got comfortable talking to, internal medicine physicians or vascular surgeons about a procedure and saying, this is a procedure we're going to do for your patient. I'm going to manage the patient before and after the procedure. I'm going to follow up with them. And I ended up becoming very comfortable with, different disease processes. So coming here to South Carolina and helping build this practice from the ground up hasn't been something that's very foreign to me. I'm in a different place. I'm getting used to a different system, but the foundation is there. And, we talk about Miami Vascular being very well known, obviously, for vascular disease. The name is, in the title. But I have to tell you, I did a ton of interventional oncology while I was at MCVI. So I was a resident in the Texas Medical Center. I rotated at MD Anderson, and the amount of oncology I did at MCVI was on that level or more. So I got exposure to, various oncology procedures like TACE or Y90 ablations, but especially in IRE, which is a procedure that a lot of people don't have exposure to. So IRE is irreversible electroporation for people who don't know. And that was another sort of area that I was brought on to build at MUSC. And that's something that I've been working on here as well. And when you're building a practice or you're building something where the device doesn't exist, you have to be very comfortable speaking with the device reps and other clinicians and people in tumor board and justifying why you would need this technology, why this new treatment is important. And those were all things that I picked up at MCVI. So, I'm just 7 weeks out of training, but I feel like the experience that I've got there has really helped me build these fields. So, I've been working on PAD and IRE. And the other thing that I was brought on, to kind of, I kind of did this on my own. This was something that was very important to me. When I was at MCVI, we were reading non-invasive imaging. So we were reading the ABIs and vascular ultrasounds. And I think that's something very unique to that fellowship that you don't get training in a lot of other places. And I noticed that was something that wasn't being done at MUSC. So one of the things I'm going to be doing is teaching our res fellows how to read vascular ultrasound. And that's going to be really important to them when they got into practice. They might be reading those, and that's going to be integral to them building a PAD practice. So those are some of the things that I focused on that are directly related to, experience and exposure that I got during my final year of training. And, finally, I think I was given this role to be assistant program director, and it was something that I'd shown that I was interested in. I love teaching. I love being a part of curriculum development, and I'd had a lot of exposure to that in fellowship. And I had all these exciting ideas about, teaching people how to read non-invasive imaging, building this practice and that. And I think that was, sort of what helped me get that position and, put me in a place where I could mentor other people as well. So that's just, a little bit about me, I guess.
That's excellent, Varshana. We're going to get time for discussion a little bit later, but real quick before you go, what was the reason that you decided to go into academics?
The biggest thing was I really like teaching, and I wanted to be a part of, the next group of interventionalists, like training the new group. I liked being part of, shaping the curriculum, changing what they're learning. And I was really inspired by how clinical our fellowship program was. And I noticed it wasn't like that in a lot of training programs. You learn how to do the procedures, you may learn a little bit of clinical medicine, but you don't always learn the long-term follow-up or the ownership of the patient. And that's something I wanted to change culturally and fundamentally within an academic program.
Yeah, I think that's definitely something that we see often in academic centers. So moving on to staying in the academic realm, but moving into a very different type of practice, we have Yoland Bryce up next to talk about her experiences.
Hello, thank you for inviting me. I'd like to clarify that I graduated in 2016. And
I was 15.
Older and has the gray hair.
Watch it.
I saw those gray hairs on Yates, and I figured he just had to be older.
He was 2015. Okay. All right. So I just have a little synopsis, and I am on the other end where Varshana is headed, but now I've been a few more years. And so this is what I've done so far with my career. And I have to say that MCI placed me firmly on the course for a successful IR academic career. So before I did IR at Sloan, I did a breast imaging fellowship at, before I did my IR fellowship at MCVI, I did a fellowship in breast imaging at Sloan Kettering. So when I completed that, the chief of breast imaging at Sloan wanted to bring me back because she liked the dual training of breast imaging and IR, and she wanted me to start a breast cryoablation program. So that's why I went there initially. And I had this love for vascular disease, but I had these possibilities that maybe I could do vascular disease at a cancer center, totally uncharted, totally not sure if that could happen, but I went anyway to this cancer center. So I started the cryoablation of breast cancer program. It was very difficult. Sloan Kettering is a very surgeon-driven hospital, and it was hard just to convince breast surgeons that that I should be treating these patients with breast cancer with cryoablation. Lots of conferences, lots of speaking, a lot of conferences where I was ridiculed, but slowly with persistence, a lot of smiling and patience, I was able to develop the cryoablation program. So I treat patients routinely now with that are not eligible for surgery or who refuse surgery. And then because of the cryoablation of the breast, I also was involved with trials to explore immunotherapy with cryoablation. And that led me to be a PI of a multi-institutional study where my institution's co-PI to study perioperative breast cancer with cryoablation. And I'm very excited that I just got funding to for my trial to study cryoablation with immunotherapy in metastatic triple negative breast cancer, because these patients are super sick and they have very aggressive tumors with very few options. So that will be starting. Then let's switch over to vascular disease, which was my passion, is my passion. So I received my RPVI shortly after leaving Miami. And I also got boarded through the American Board of Vascular Medicine. And all of this was to try to develop credentials to say that I should be trusted to do vascular at this cancer center. I started a vascular lab there with my RPVI, and I used the justification that the fellowship needed the vascular lab for their training. And to get that promoted, I had to talk to countless people. Anyone who would listen to me, I talked to them. I gave conferences. I engaged anyone who had a research question that had some kind of vascular question. I said, come and do your studies at the vascular lab. Don't just do the AVIs in your office. And so slowly, the vascular lab has built, and now we have a lot of patients coming through to get imaged. So that's very, I'm hoping that our fellows will also be able to sit for the RPVI now that we have the vascular lab. And then I started a PAD program here at the Cancer Center to treat people with claudication and CLI to improve their lifestyle and outcome. And as you can imagine, it was a lot of convincing to try to tell people why we should treat PAD at a cancer center. So again, I went on the trail to champion it. I met with anyone who would listen to me. I've given grand rounds, I've given multiple lectures. And so that program has been growing, which I'm very grateful for. It's like a lot of work. And as Varshana was saying that we learn practice building, it's true. Like you hit the ground with a lot of energy and a lot of running, but you get there. Again, a lot of patience and persistence. I even do this thing where I get notification with anyone who has an ICD-9 or 10 code with PAD, and I contact the referring clinician and tell them I can help them with their patient. And then I started a vascular clinic. I kept telling our chief that please, we needed to call it a vascular clinic, because I was there talking to all these people, yet it didn't look like I had the endorsement of my service to say that IR had a vascular clinic. And that took a lot of work, but we have our vascular clinic now, and they see that we have endorsement. It's easier to say, please refer your patient to the vascular clinic than to say, okay, just see sign up for the clinic, I'll see the patient. It sounds better. So that is good. And then I have a new trial that is trying to assess the benefits of PAD screening in cancer patients, because in my review of the hospital data, there is severe underdiagnosis of PAD, especially in Black patients, and it's affecting outcome. So that is something that I've received funding. So hopefully we'll be able to have some data with regards to screening for PAD in cancer patients. I just finished doing a junior investigator project for the research consensus panel for SIR. The topic was to close the gaps of racial disparity with CLI and amputation, and hopefully that will lead to more projects to improve screening and care in patients at risk for PAD, especially those that are underrepresented minorities, because they're the ones most at risk. Then there was a lot of problems with acute limb ischemia at my institution, that there were patients, because of delay, nobody knew about ALI. A lot of patients had amputations or near amputations. So I was asked to head a QA project to improve the outcome in ALI. So that we've championed, and in a retrospective review of our hospital data, we saw that outcome depends on when you start heparin. So patients who start heparin at greater than 6 hours, 6 hours or greater, have a worse outcome. And so we published that data, and that is our aim. So we're making changes on that. Also with PE, there was no consensus with how to treat massive or submassive PE at my institution. So I was asked to make an algorithm, which we've been using, and hopefully we'll get a PERTS team soon. So that's pending. Lastly, as Brian said, I am fellowship program director. I started January, and when I was given the fellowship or / IR residency, it's still in my mind to call it a fellowship. It was not where a residency needs to be, and having trained at Miami and knowing what a great fellowship looks like, I put that in my mind, and I worked really hard, and I'm very proud of the changes and the vision that now we have, and all of that was because of the vision I was given. So I'd like to conclude with the different things that MCVI gave me to be able to accomplish what I've accomplished thus far, and I'm really hoping and trusting that things are gonna continue to get better. But number one was skills. I was able to take the RPVI, get boarded through the American Board of Vascular Medicine to be able to confidently do PAD procedures. Number two, clinical acumen, practice building. I started the PAD program, breast cryo program, the vascular clinic, IR residency, mentorship. I can't tell you how many times I called Dr. Benenati here in tears, and only Dr. B knows. And he was always very patient with me and would talk to me. I've also reached out through Ripo Gandhi, Dr. Pena, Janice Newsome, who is also a graduate of MCVI and chief at Emory. I've called Brian Skiro to help me to treat a renal artery pseudoaneurysm or popliteal artery aneurysm. Also opportunity, MCVI has opened the doors to lecture at different places, CIO and ISET. As Varshana says, we are a family. It doesn't matter if I've ever met you or not. Once I hear that you're from MCVI, you're my brother or my sister, and I know that you will do for me what I need, and I will do what you need. It's forever a family, and my co-fellows are my brothers forever. And also the spirit of not giving up, of fighting, so a lot of trials. It's not easy to be in a place that especially may not be open to your ideas or your way of doing things, because we do things very uniquely and very clinically at MCVI. And just to have this spirit of not giving up and a family to support you, I think is unparalleled. And that has been my biggest gift, having come from MCVI. All right, thank you.
Yolanda, thank you so much for that discussion. I mean, we are so proud of all the work that you've done at Sloan Kettering Cancer Institute. You opened their eyes to the importance of treating vascular disease in cancer patients, which is really a prime area, as you said, for the types of treatments that can be performed. Okay, last but certainly not least, we're going to bring up Timothy Yates for his discussion and the incredible work that he's doing in the outpatient centers. Tim?
Thanks, Brian. Thanks everybody for having me. It's really great to be here, and for all of you that are watching and listening. If this is on your radar, it's really a tremendous opportunity. I think, Varshana and Yoland have had really done an impeccable job. I think they've got an incredible pedigree, but I think what they're doing with their skills is the most important thing. And I think MCVI really is absolute, top of the line for getting you into a place to be able to achieve at least your professional dreams. So, I guess, you're here because that MCVI is exactly that cream of the crop. You're going to have the opportunity to work with phenomenal staff, unparalleled resources, as Dr. Skiro alluded to, in terms of the imaging and the opportunities to use different technologies. And one of the things at MCVI, I think that for me was probably the most important, is it's truly representing a representative of a vascular program. And I can't tell you how many interventional radiologists come out of training not knowing how to read a carotid ultrasound, not knowing to interpret an API, and certainly not having to do an angiogram, let alone perform an angioplasty or a stent. And so for me, that was extremely attractive. Probably the most valuable part of MCVI, I think, is this brotherhood and sisterhood, and it really is a family. I think Yolanda alluded to it nicely. Once you're in, you're there, and once it's a kick to go out to meetings and meet people, and they say, yeah, I went to MCVI, blah, blah, blah. And this, oh, I've seen you on the wall. I know you, it's really a cool family. So about you, if you're going to come here, if you're going to interview here, remember your CV, your research, your scores, your letters, they're all impeccable. We all know that. Everyone's great. Everyone's the best. But if you're here, it's about what makes you special. Remember that. They got to ask themselves the question when they're interviewing you: can they stand to work 12 months and essentially every single day of those 12 months with you? And so you got to separate yourself from the pack by showing what makes you interesting and how you're a good human to be part of the team. So I'm originally a Nebraska native. I moved to Miami, ended up at Mount Sinai, Miami Beach. For residency, where I did surgical internship and diagnostic residency, radiology. And I was originally actually slated to go to Stanford for a body imaging fellowship. I was in the midst of a divorce, and I'd gone back and forth on whether I was going to do IR. I didn't know if I wanted to have the unknowns of where I was going to go, because I had a 3-year-old daughter at the time. So I elected to do a different path. And about 3 months before I went to fellowship, I was supposed to go to fellowship. I was at Mount Sinai at that point doing my 6-month mini fellowship in interventional radiology. I was kicking myself for not going after IR, and the SIR message board get a message that there's an MCVI fellow has a family tragedy, not going to be able to attend MCVI. My now wife looked at me and said, I think you should probably apply for that. I said, I don't know. This is the cream of the crop. These guys are the best. They're a factory. They're going to kick my butt. She said, apply, go down there. And I went down there and got a chance to meet the crew. And, I got Dr. Benenati and says, well, Tim, we really like your application. Your letters are really great, but I don't know about this Mount Sinai thing. I'm going to have to do some calling about you. And long story short, we fast forwarded and ended up getting in and having a phenomenal time of it. And, why does it matter? Well, I've kind of dedicated myself to CLI and what I do in my practice. And this place was lights out for the treatment of CLI. Got a really great opportunity to do everything from carotids to aortas to anything vascular, but really got a great experience. Learned how to do pedal access with AP. I remember him standing over me saying, show me the needle tip, show me the needle tip. You don't get to go forward unless you show me the needle tip. And you all laugh about it, but everyone on this screen knows exactly what I'm talking about. So how did that translate to work? Well, I went out and I worked in a hospital practice for 4 years as an employee. Went back to Mount Sinai, talked with Dr. Benenati at the end of, toward the end of fellowship. And, he talked with my former partner at the time, and we talked about that opportunity and went there. And it was a great opportunity because it was a very heavy vascular program, but it was also very call heavy. It was a 2-guy practice for, probably 4 people's worth of work. There wasn't a lot of room for growth from the standpoint of practice development. But I did have a really phenomenal, intense training after fellowship in vascular care and treatment of very sick people in the ICU. I got to develop the oncology program, did a lot of Y90, and really didn't have a lot of hierarchy that I had to work through in order to learn how to do cases. So I had a very good experience, was very busy and did a lot of cases. So that was a nice experience. But as I was at the end of that contract, I felt I was missing something. And, I see a couple of the ladies here doing academics. I'm kind of just the opposite. I'm kind of the person that likes to do the work. I like to just see my patients. I like to shake their hands and talk with them. I like to be in the clinic, and I like to be doing cases. I like to be doing complex cases, spending my time, in the lab. That's really where I thrive. And one of the other things that I found in my now practice, which is the outpatient world and the private practice realm, is that I also get to do a lot of marketing. I get to build the practice. And if I have an idea to grow oncology and Y90 in our office, I can do that. If I have an idea to mix marketing and imaging, et cetera, I can do that. And so it's been kind of a kick to be able to grow those parts of the practice. The office, we also do a lot of education. We have residents, we have students come through, but we also do CLI research and trials, clinical trials for industry, as well as in-center research across our 6 centers. Additionally, it's a little more concierge. I have a lot more control over my day, and my patients really get the one-on-one with me that I want. When I'm in the room, it's my room. When I'm in the clinic, it's my clinic, and there's really no one in line. And so I have a lot of control. With that control, obviously, on the other hand, comes a lot of responsibility. So you ask, why the office? Is it safe? Is it as safe as a hospital? Aren't these patients too sick to be treated in the office? Can you really do high level work in the office? And the answer is to all those questions is, well, is it safer in the hospital? It depends on which hospital. I think the MCVI folks can agree to that. It depends on whose hands you're in. It depends on how ethical and how good they are and with their judgment. And honestly, with a lot of the work with an appropriately chosen patient, I can treat people in the same way or to a higher level than I would in the hospital. And so we practice a very algorithmic approach. Patient selection is very important. In some ways, it actually may be more cost effective to payers to treat them in this manner. Since the pandemic has hit, we've seen a major boon in our business and in our patients, because a lot of patients weren't able to be treated in the hospital. And for patients who have critical limb ischemia and a limb threat, they really don't have 3 to 6 to 9 months to wait for that procedure on an elective basis in the hospital. So we actually did a lot of work and did a lot of limb salvage in that time. So we found that to be very beneficial. You also, in the outpatient world, when someone refers to me, they're getting me and they're getting my staff, and they're getting those people that know how to provide that sort of one-on-one care, and they're getting that dedicated oncology, comprehensive care, and limb salvage team. And really, it helps because we get to make our refers look good, and it's a nice relationship that we've developed. So, how did MCVI get me here? Well, I got my butt kicked when I went there. And I think everyone that starts there has their mind made up that they're going to do a great job, but you don't know what you don't know until you get there and you're shown what you don't know. I can't tell you how many times Benenati came in the morning and said, "Tim, did you sleep here again last night? You got to go home and see your family. You got to get out of here." But I'll tell you what, the training really gave me a complete comfort immediately working in my job at the hospital with critical care, complex vascular disease management, not only in my own technical ability and my clinical decision-making, but the way that we build relationships. And that's something that's critical. The multidisciplinary approach at Baptist is something that's been espoused from the beginning. Vascular surgery, cardiology, endocrinology, infectious disease, interventional radiology, and imaging all work hand in hand to try to provide a top level of care, which is why they've been so successful, at least in my opinion. And again, partnership is something you have to learn, and that that partnership is something that you learn as part of your fellowship group. You really learn how to make it work amidst adversity, because everyone's tired and everyone wants to go home. And I think that really raises the standards. So I'm still thankful. You can say hi to everybody. My daughter's coming in. I still say okay. So, I'm still very thankful for the opportunities to be given. I think that the lessons that you learn here will apply to everything. And more than just the lessons you learn there, will teach you how to learn. And you're going to be able to be scrappy, research, and how to figure things out on your own. Because honestly, no matter what you learn in fellowship, you kind of learn it all over again when you're in practice. And you need to have the people like Yolanda and Varshana said, we call our fellowship groups every single day. I call Jim, I call Alex and Brian. We talk about cases, we share cases and ideas, research protocols. So it's a phenomenal family, and I'm proud to be part of it.
Thank you, Tim. That was really excellent. So for everyone that's on the webinar, this was really an opportunity for 3 different perspectives of the training program and what that's really done for each of them in their professional careers. And we're very proud of all the hard work that they did. I'm going to bring in some of my partners here. I see we have Jim Beninati, Alex Powell, Raj Narayanan, and Andy Niekamp. If anyone else is there and I'm missing you, please speak up. What I want to do now is just open it up for some question and discussion, a little bit about the program and some of the things that you've heard tonight. Jim, any comments to start us off?
First of all, yes, Brian, thanks for organizing this. Is a great opportunity for people to learn about the program, and thanks to Yolanda, Varshana, and Tim for their presentations. And I think what I could say over the years is that, this program, I think what you heard each person say is that they feel engaged and they feel part of a family. And yet, sometimes if you go online, you read in these blogs and chats like Aunt Minnie about how hard people work. And the reality is that I think the only thing I'd like to leave you with is that there's different kinds of hard work. There's a kind of hard work that you benefit from and grow from, and it helps you and enriches you. And there's a type of hard work that's more like scut work. And I think that the hard work our fellows invest in that 1 year is what they're doing to create the next 40 years of their career. And that's why I think that family feeling is there, because sometimes in life, the harder you work at something, the harder it is to ever give it up, and the more you want to succeed. And because I think all the faculty, and I mean every single one of the people at MCVI right now, is committed to training. When you're working hard, you feel that people are committed. They have your back. They're helping you. And that's what helps form those bonds. I think it's a very special place. And I think all 3 of the people who spoke kind of brought that out well. So that would be my comment, Brian.
Alex?
Well, it's hard to add anything more than what's being said. And to follow Varshana, Yolanda, and Tim is pretty difficult. But it just typifies why we're proud to be working in Miami, to have a chance to interact with people like this and to play a small role in shaping their future. But I don't think I need to say anything more than just listen to the prior 3.
Raj, let's have a little bit of a discussion as far as how things have changed over the years with interventional oncology. And I'd like to bring the others, the former fellows, into this as well. Tim, I know that you and Yolanda had a fair amount of experience with some of the cases in interventional oncology. Obviously, over the past several years, that the number of cases that we do in interventional oncology and the types of IO cases has drastically increased. Raj really brought a big change as far as ablative therapies to Miami Vascular. We were certainly doing many different types of ablations prior to him starting, but definitely we've seen a big ramp up in those since he's been here. In addition, the introduction of IRE, which Varshana was able to bring as a fresh graduate to her training program. So Raj, you want to talk a little bit about some of the IO things and initiatives that we're working on?
Sure, Brian, thanks for having me. And once again, congratulations to all 3 of them. Yolanda, Varshana, and Tim. It was inspiring to listen to their journeys and what they've accomplished after their fellowship here. As far as my focus is, while it's interventional oncology, one of the key things I feel is unique about MCVI is the well-rounded approach, not just with the variety of cases, but also the clinical background and the training that you get, which is, in my opinion, unique compared to any other program in the country. As far as oncology goes, I think we're proud to say that we have easily one of the most diverse interventional oncology programs in the country, where we have every transarterial treatment and ablative modality available. Not just available, but we also do a lot of these procedures, Y90s and TACE and combinations, microwave, cryo, and IRE. And then we're also expanding it, and not just in the clinical space, but also in the research space. MCVI is one of the 7 sites chosen for the histotripsy trial, which is a non-invasive modality currently being used in an FDA-approved trial for treatment of liver lesions, liver tumors. In addition to that, there are at least 10 studies that are going on in oncology, in addition to the vast number of studies that are happening in the vascular space. So putting all of these together, I think it provides an incredible opportunity for somebody interested, not just in training, but also in the research aspect of things, to be in the absolute cutting edge. And as everyone before me spoke about our infrastructure, I think it's by far one of the most unique environments to work in, where not only do you have, it's not just the suites that are there, but also the colleagues from other specialties. One of the first things that struck me when I came to MCVI was when I had a situation in the CT room, and in less than a couple of minutes, I had a cardiology colleague walk in from the next room to come in to ask if we needed any help, and vice versa. There are many times when our IR colleagues are helping the other specialists in their room. So there's not only just a collegiality within the specialty, but also an interdisciplinary collegiality. So all of this makes it, in my opinion, one of the most unique programs. And my favorite line for the MCVI fellows is, I consider them the Navy SEALs of IR, because you train hard, but when you come out, you are a very unique and specialized group like no other in the country.
I think that point is well said, Raj. Definitely, we do require a lot of our trainees, and really the reason for that is to produce people such as the 3 excellent former fellows that you see with us tonight. I mean, that's really the goal of the training program, is to make you the best interventional radiologist you can. And really a big part of that, Andy, if you're available, a big part of that is the clinical training that we provide here. And that clinical training really is one of the main focuses, and one of the things that I think sets us apart from some of the other training programs, because although other training programs say that they provide clinical experience, this is something that we've really done for the past 30 years. Andy, are you there?
Sorry, Brian. Yeah, I'm here. I was muted. No, I couldn't agree more. I was actually just, while we were kind of reminiscing on all those points, I remember, so I was a fellow in 2019 to 2020. So I graduated about a year and a half ago. And I remember sitting down in my exit interview, and Jim and Brian both asking me, so, tell me, what about this year kind of, stood out to you or surprised you the most? I'm sure most people would say, cases, and honestly, the variety of cases and what we were able to do here, the types of things that we get involved in is incredible, and definitely not seen anywhere else in the country. But it was really how you learn to think was the most incredible thing that came out of my year. I was not thinking as a proceduralist. I was not thinking as someone who's consulted to do a procedure. I was thinking as someone who was consulted to evaluate a patient and actually be a clinician. And it's very unique here to Miami, and something that we harp on every single day, because it's the way that we actually practice. We are not asked to put in lines. We are not asked to do procedures. We're not asked to do things. We are consulted as a service. And and it's really the way that medicine should be done. And that was the reason why I wanted to stay here too as an attending, is to be able to continue to practice with these guys who preach and live it every single day. I do also just want to really say that family, that the MCVI family thing is absolutely real. It transcends classes. And I like, at the end of my fellowship, I remember when I was saying goodbye to the other 4, I just said, you know, outside of my wife, there aren't 4 other people in this world that know me better than that, of all the things that you go through. So it's really an incredible place. It was long hours, but I don't regret 1 minute of it.
Thanks, Andy. Just to remind everyone, the chat box is open if you want to put some questions in there, or in the QA also, you can ask questions. I think you can even unmute yourself if you'd like to chime in with a comment or a question. One of the questions in the QA is, we're going to direct this to Varshana as a recent graduate. What are the most difficult elements of the fellowship for fellows to adjust to? What are some of the tough things, Varshana, that we had to get through?
Well, I think, you know, in the beginning of any fellowship or final training program, it's like there's that analogy that you're trying to drink water from a fire hose. It's a lot of information coming at you, and you know, it's not just the procedures. That's what a lot of people focus on, the technical skills, but it's, you know, in all realms. You're learning how to read non-invasive imaging, you're talking with clinicians. So it's, in the beginning, it's very hard to get a grasp on everything coming at you. And then, you know, I think after a few months you adjust, but I think for me, the biggest thing to adjust to was this idea of like what Andy Niekamp said, is that we were not consulted to do a procedure. You're consulted to take care of a patient. And that was very different from a lot of the programs that I had rotated through or that I had experience with. And I remember sometimes in morning meeting, we might say something. And morning meeting, for those of you who don't know, is where we as a team ran through the cases for the day, so everybody knew what the plan was. Someone would make the fatal error of saying, they asked us to do this. And, you know, that's, you realize in training that a lot of referring providers, you know, they don't understand maybe what they need. They want you to do something for the patient, and they put in an order of what they think, you know, from their knowledge of interventional radiology is the best thing. But you start to figure out that they may not always know what is best, and that you're the clinician, and that you have insight into this field, and that you can, this is an opportunity to educate them and, you know, really take care of the whole patient. So that was sort of a thing that I had to switch in my thinking fundamentally.
Raj mentioned a little bit as far as research in IO. Certainly we are starting some interesting topics in IO research now, and we've had several in the past. But we also do a lot of clinical research in vascular disease as well. Let's just go back a little bit. It is required that each fellow do a scholarly activity, which requires some element of research. You know, the ultimate goal is to have something published. But at a minimum, it is required that we have a grand rounds presentation where the data that was obtained by the training is discussed. Let's go back and talk a little bit about that. Yolanda and Tim, do you remember what you were involved in for your scholarly activity and your research back then?
Yeah, Frederick Bauman was our research scholar, and we had a project that we worked on looking at closure devices and looking at 6 to 8 French devices and 9 to 12 French accesses, which was a publication that actually got submitted and accepted to JVIR. And the fellows had a number in my class had a number of similar projects, some original, some more longitudinal over their experience of their care of their patients.
Yolanda?
Yes, I did a retrospective review of trends in endovascular repair in patients with hostile neck, and the differences between suprarenal and infrarenal fixation. I know it was interesting finding that the patients with hostile neck with infrarenal fixation actually did better than suprarenal fixation. Anyway, I'm not reading much into that, but that was our finding, and we published it in JVIR.
Yeah, that was interesting. I remember that that presentation and some of the discussion we had afterwards. Varshana, what were you involved in?
So my research project was on intravascular lithoplasty in common femoral artery lesions. And what's interesting is while doing that project, I got, I did a lot of research on the technology, and there's a meeting called the Sanctuary of Endovascular Technology, which is in Kiowa in February. And I'm moderating a panel on heavily calcified lesions, and I'm speaking on IVL because this is something I'm very comfortable with now. So
excellent.
Thanks
Good for you. All right, so there's a question from the audience. It says, in between seeing patients doing cases and in the clinic, how do fellows get enough non-invasive vascular volume to sit for the RPVI? Everyone's going to laugh a little bit at that question because
That's
the
cute.
volume that we have for non-invasive vascular is quite hefty. You guys want to chime in on that?
So the thing that I loved about MCVI is that it's like real life. In my practice, I'm seeing patients, I'm reading ultrasounds, and I'm doing cases. I'm dealing with a patient on the phone. I'm dealing with a referring on the phone. I'm handling marketing ventures. And this is a lot like how it was there. We had a very busy, just an amazing vascular lab. I really would say unparalleled, at least in my experience, certainly. And you're going to do a lot of reading, MRA, CTA, and PVRs, ABIs, ultrasounds. So,
Yolanda, anything you want to add to that? I know that you got your RPVI specifically so you could get your lab going at Sloan Kettering.
Yes, as Tim said, it's funny to say how will you read it enough. You will read enough. It doesn't, I don't know how, but you definitely read. I think our PVI requires that you read 500 studies, and we read well over 2,000. So
it's a lot.
You'll get enough.
You can literally
Definitely.
walk out of your fellowship and take the test. You don't have to study for it. Just take the test. You'll be fine.
That's true. There's very few tests in my life where I felt so comfortable when I left, and the RPVI was one of them.
Tim, did you want to chime in with anything there?
I wholeheartedly agree. I mean, I literally went and sat for it as soon as I was done. I mean, we read so many studies. I felt super comfortable. And I think, Varshana mentioned that, and Yolanda did too, in establishing vascular labs in their practice. It's a no-brainer. And it's a wonderful service for your patients. It's an important tracking and surveillance method, pre and post intervention, to understand what changes you're creating as you're treating and healing these patients. So phenomenal experience. I couldn't be more prepared.
So there's a question about some of the evolving types of procedures that are coming up, and if we're still really doing some more of the innovative stuff. Certainly, Raj is involved in a new procedure of percutaneous histotripsy, which is a method of performing a percutaneous ablation using ultrasound. That's something that we're starting up as a new procedure. You heard Varshana talk about intravascular lithoplasty or lithotripsy. That's something else that we're working heavily on as well. And new procedures as far as MSK interventions. There's a question about that specifically, and we're definitely looking into doing more of the non-spinal cementoplasty and the pelvic screw fixation. Pelvic screw fixation is really something that we've been talking about a lot over the past several months, and something that we're getting more involved in. We actually have a new orthopedic oncologist that is interested in us performing some of those procedures. So I do see that area is something that's growing, that we're going to have some new and diverse things in. Raj, is there anything else that you wanted to touch on?
No, I think even with the existing technologies, there are some innovative stuff that we're doing. We have, I'm only talking about the pancreas and the oncology stuff. We have an FDA-approved trial for pancreatic cancer, 2 of them actually, intraarterial with Dr. Gandhi, and the percutaneous IRE trial in pancreas, the direct study. But even though these are studies, these are also clinical experience that you would get where you would be treating these patients with pancreatic cancer. I think that's another unique feature of our program.
Yeah, we're also doing a lot of spyglass procedures as well.
We forgot about that.
Getting to those procedures is something that's fun and different for sure.
Yeah.
Brian,
Okay.
there's a question about did all the former fellows have robust PhD experience during residency? If not, what was the transition like? If you don't mind, I'd like to just speak on this. So
yes, please do.
I did a breast imaging fellowship before I did IR. So for an entire year, all I focused on was the breast, and I was very nervous because then I would be going to one of the most amazing residency programs, but very heavily with vascular disease, something I hadn't done at all. And I was very nervous. However, I may have been very far behind when I first started, but the attendings are 100% dedicated to you and your training, your learning, and they are committed to making you the best physician that is possible to exit their doors, because you wear their name on your back forever. And they get you there. So even if you didn't have a lot of PhD or any vascular experience, they will get you to the standard of the most experienced PhD person.
Yolanda, if I could add to that. Thanks, Brian. I say this to every fellow coming in. I can speak for my partners. I don't think we really care if you've even done one arterial access before you come to this institution. But what we do care about, and Tim answered this offline or in the questions, is, what does it take to be good? And that's an intellectual curiosity, a drive to be better, to learn from every case. And again, it's not experience coming in, but it's the experience you get when you're there in Miami for that year.
And Alex, to that point, if I could just add, to just expound on that, when we look at applicants, we're not looking at people from from any one program. If you look at the diversity of programs we choose from, it's really all over the US. It's large programs, small programs, big academic programs, community programs. The three people on this, the three former fellows, all came from very, very different types of programs. So no one is pigeonholed, no one is stereotyped. We're, as Alex pointed out perfectly, we're looking for a personality traits and characters without any prejudgment on what you know in advance or where you're from or what the reputation of, whether it's Ivy League or a small community hospital. If you have that kind of thing that we're looking for, then we want you.
Perfect.
Absolutely, Jim. Totally agree. Well, listen, I think we could go on and on about what we think of the training program and hear more and more from our former fellows about all of the great things that are accomplished. I do want to say, for all my partners, that we are so very proud of Varshana, Yolanda, Tim, and many of our other graduates over the years who have really made something out of their careers, and we're very happy to be a part of their training to get them to the point where they are, and we're so excited to hear how well they've done in the beginning and years since their training. So with that, I would like to thank everyone for joining us. I am going to put this slide up. Give me 1 second here. Okay, so this is how to apply to the training program. So how to apply to Miami Vascular. We do accept applications only through the ERAS system, and we accept both ESIR for the 1 year position for the final year of training, and as well as the non-ESIR applicants that are coming for the 2 years of training. Note that our sponsoring institution is the University of South Florida, and we are listed under the University of South Florida under their independent interventional radiology residency program, specifically in Miami. So when you're looking for where to apply, this is the location. It's the University of South Florida Independent Interventional Radiology Residency Program in Miami. Applications begin soon. So just a couple days from now on November 17th, ERS starts sending out applications, and interviews are going to be in January through April. Keep in mind that we will receive your application. We're going to look at it as soon as it comes in. It's going to take us a while to send out the interview dates. We have to get things organized on our end as far as when the interview dates are going to be held. So please bear with us and keep in mind that we're going to review each and every application as it comes in. We're certainly very interested in hearing from all of you. If there are any questions, please feel free to reach out to me. My email can be found on the website, as well as Huguette Acosta, who is our residency coordinator. We are looking forward to hearing from you for sure. And once again, thank you all for joining us for the meet and greet for Miami Vascular. Everyone have a good night. Thank you.
See that pink bow tie.
Thanks, Brian. Great job.
Thank you all.
Love the bow tie.
Oh, that's a classic. Thanks, guys and gals. It's good to see you.
There's his bow tie.
There it is. There it is.
Good night, everyone.
Have a good night.